I can hear you.
Oh, that's great.
I'm quite happy to listen to the next presentation. I was actually looking forward to it. So.
Okay. So yeah. So do you want to talk before that, or would you like to? Maybe you can talk a little bit before that, and then we also start the presentation. Maybe just after 5 minutes of your introduction, perhaps. So maybe I should introduce you to the audience. Professor Stumberg has been a collaborator for the last 20 years. Yeah, that the face is the light is not on your face, so a bit dark there. And he's a great friend, and we have collaborated over this last 2 decades, and he is the director, the founding president of the Society for Complexity Sciences globally, and he's also a founding editor of the complexity section of Journal of Evaluation of Clinical Practice UK, very popular PubMed index journal, and of course he's written so many books and so many articles on complexity, and he is a globetrotter, and he is there in a lot of conferences, and I was really looking forward to meeting him. And in fact, we had one opportunity where he came close to us in Singapore, where I just missed meeting him. But I mean, this is also great. Looking at you online is also a great thing. Can you just? Yeah. So yeah, over to Hakim. Can you just?
I just tried to share my screen. I'm not sure.
Yeah, no, we can see you, but we can't see your screen. How will he share his screen?
Cannot share.
Can you allow him to share his screen? Yeah, we are doing it from our end. Let's see. Yeah, we have made you a presenter. I think now you should be able to.
Yeah, let's try. Here we come closer. Let's see what happens.
Yeah.
Do you see anything?
Not yet. So can you just see he's trying to share his screen. So what can be done? He is the he's not. That is the one. Yeah. Professor Stumberg. Yeah. Yeah, he's the presenter. Huh? Okay. Now you're the presenter. So now you can share your screen.
Okay, I'll try again. Here we are. That looks better from my end.
Right. And it looks better here as well. So
okay. Rakesh, thank you for your kind introduction. And unfortunately, I remember we were supposed to meet, and then I had a back injury and couldn't come. That goes back quite a few years now, doesn't it?
Yeah. That's almost 10 years, I guess. More than that.
Yeah. Thanks for inviting me, and I think you have a very interesting topic for your conference. I think it's a difficult topic as far as I am concerned, because in the end it requires a lot of deconstruction of concepts of complexity, deconstruction of health and disease and of medical knowledge, before one can put it all back together to enable you to provide better care for your patients, or more accurately, this particular patient in front of you. And I was very encouraged to hear the end of the last presentation that highlighted all the benefits of it. I started with an overview to provide you with guide for the journey through this talk, because it really touches on a lot of different aspects of complexity, and I'm not completely sure how well each of you is versed with complexity principles. So the first thing is to consider what complexity is and how it differs from reductionism. The next part will be about health through a complexity lens. And then we need to look at medical knowledge and what is it, what is the base of it. And the Kuhn framework developed by Kurtz and Snowden, I think provides a wonderful way of making that explicit. And then comes as the next part, the nature of complexity of health care, which is probably the main focus of your conference today. And after all that theoretical stuff, I provide you with a case study to show you that it is quite an easy way to implement complexity thinking into the healthcare delivery. So, first things first, what is complexity all about? You need to understand that the common English use of or meaning of the term complexity usually refers to something that is difficult for me to understand. That has nothing to do with complexity in the way sciences sees it. The scientific meaning can be reduced to, and excuse a pun of reduced to, the understanding of interconnectedness and interdependency. That's in simple words. If you don't want to know anything more about what is complexity, think about interconnectedness and interdependency. And the second part will be to understand what constitutes a system. And the system really has three key characteristics. The first is the system consists of two or more independent elements that and these elements do behave as a whole. That means any action depends on what other parts of the system are doing. And the third part is that the properties of the whole are not present in the individual parts. That means a system cannot be taken apart without losing all of its properties, and you really then cannot understand how the system functions. The properties, to properly appreciate the nature of complexity, one needs to understand what we often struggle with. We have been socialized to believe that we can understand anything by taking it apart. And the all-persuasive prevailing Newtonian reductionist worldview is really what drives most activity in society, and no less so than in medicine. Reductionist thinking equals taking things apart and exploring the behavior of each of the parts on their own, and then to aggregate the understanding of the parts, put it back together to understand the whole. This process actually has a name. It's called analysis. And it's really good if you want to understand inert mechanical systems, the non-living systems. However, if you want to understand the complexity of the animate world, you require exactly the opposite, which is called synthesis. If you you are not taking things apart, you understand, you try to figure out how the particular system of your interest is situated within the broader context. What is it embedded in? And you explore the behavior of the particular system, how does it impact on the parts. By understanding the whole, you require to understand the context in which the phenomenon occurs. And often there's this rather, let's say, stupid saying that in a system, the system is bigger than and different than the sum of its parts. It is sort of a useful metaphor in a way, but it, to me, has a bit too much of the meaning to segregate it from reductionism in a mechanistic way. But that's for a longer discussion. So, let's look at health as an interconnected and interdependent whole. Complexity thinking reshapes our understanding of health as an interconnected and interdependent whole. A person's health is as much impacted by our somatic or bodily, or social, or emotional, and or sense-making experiences. Health is a whole person state where each of the four dimensions of health are in balance. And if you construct a complex dynamic system of health, you get a picture like that. If you look at the left-hand side, what you see is how over time every person's health experiences are somewhat influenced one day more by your bodily experiences and others by your social or emotional or sense-making issues. And depending on how strong the impact of one domain is, do you get a drift into that direction. If I plot that into what is called a phase space, like what you see on the right-hand side, you actually find that the dynamics of your health form particular patterns. On the top left, you see the state of health, where there's very little fluctuation from the perfect center. If you look at the bottom left, you have the situation of an acute biological or somatic illness. On the top right, a picture of chronic disease. In this case, it's a chronic physical disease, but you can essentially turn the loops by 90 degrees, and you then see that you have a psychological or mainly semiotic problem or a social problem as a driver of your chronic illness. And the final pattern is that of somatization, where you have two states, stable states that can suddenly and abruptly switch over. Let me be a bit provocative here and say to you that health is only an experience and has little, if anything, to do with the object of disease. Just consider the question of a patient who asked me very early in my career, a young lady dying from metastatic breast cancer. Doctor, I know I'm dying, but tell me why I'm feeling so healthy. Are you perplexed? Or have you actually come across a patient like that yourself in the past? We have been made to believe that our patients' problems can be objectified and thereby simplified into unambiguous disease entities. Hence, we transform the subjective of the patient's complaint into the objective of disease, the thing we have been educated in. Eric Cassell, famous philosopher of medicine, described it in this way. The question of chest pain becomes a question of coronary artery disease, for which we have a technical solution, whatever form of revascularization works. But as you all know very well, not all patients with chest pain have a cardiac problem. And if you have worked in primary care settings, you find that most patients with chest pain don't have any heart problem at all. Which leads to the next part, which is the basis of medical knowledge, and Eric Cassell's observations are the perfect segue into those elaborations. Our knowledge base is actually not as solid as the textbooks make out. And the Kuhn framework allows us to get a more realistic appreciation of our knowledge base. A few things in medicine are universally knowable, and most things we pretend to know for sure about a disease are not well researched at their physiological level and or their clinical management. What we believe to know is based on averages. The average behavior of the average patient that does not exist. Complexity sciences tells us that the dynamics of interactions of the same parts can result in vastly different outcomes. So the Kuhn framework distinguishes what we know in 5 different domains, and they are termed the obvious, the complicated, the complex, and the chaotic domains. And you have the 5th domain in the center, where things reside that cannot be ordered into any of the 4 particular domains. And there's a reference to the paper, the theoretical framework of the Kuhn framework is very interesting, but would be too long to present to you here. If we look at the knowledge domains, you can pragmatically explore knowledge in different domains. The very much obvious knowledge base for medicine would be anatomy and to a large degree physiology. If you are looking at the complicated domain that deals with a specific knowledge of diseases, whereas in the complex domain you require knowledge about illness. And in the emergency domain, you really have, initially at least, no real knowledge about what's going on, and you need to do something to see what happens. If it works, you go to the more complex domain. If you fail, you go to the obvious one, and you all know where you then end up, don't you? If one looks at knowledge from a structure perspective, our obvious knowledge is highly structured, and our complicated knowledge is based on the logic of disease mechanisms. Our complex knowledge is based on interdependencies, and the complex knowledge structures arising from the chaotic knowledge structures arise from innovation. Gaining knowledge in the 4 domains has particular methodologies and practices. There's EBM for the obvious, guidelines for the complicated, pattern recognition in the complex, and trial and error approaches in the chaotic domain. The way we develop the knowledge that we require to become good physicians is time dependent. And in your undergraduate training, you really learn a lot about the obvious structured knowledge base, and to some degree something about the disease-specific bits. your postgraduate training is often really focused on what are diseases and how do you manage it. Whereas when you come to the complex domain, that is something you learn in primary care settings, and it is also quite a bit a matter of experience. To develop experience really requires time, and no one should be disheartened that they are not as good as their supervisor in clinical practice, who has got quite a bit of experience already. And finally, one needs to distinguish that the explicit knowledge base is something that can be taught, but the implicit knowledge that resides in the complex and the chaotic domain really is something that cannot be taught, that can be only passed on by an experienced clinician to a novice in the context, by sharing the experiences in the moment. So, how can we be sure that our work improves the health of our patients? Firstly, we need to appreciate that health is the norm and disease is an exception. Health and disease distribute in a consistent pattern, which is called the Pareto distribution, or the 80-20 split. And if you look at where medicine resides, you have that 80-20 split again in terms of where healthcare is provided. 80% of healthcare is provided in primary care, 20% in secondary and tertiary care, and in that sector, 80% is provided in secondary care and only 0.8% in tertiary care, which is usually called the university hospital. So if you think about your education, what it really means is that you only have seen an absolute fraction of what people's health and disease experiences are all about. Which leads to another phenomenon to understand about health and disease. Disease is a loss of complexity. Aging and diseases are associated with the loss in the dynamics of your physiological function, as well as responses or maladaptive responses to perturbations. And as you see in the image, every time you survive a perturbation that is significant enough to disturb the system sufficiently, you have a homeokinetic response. It means you get to another stable state that is different to where you have been before. And equally, disease dynamics are characterized by further loss of complexity. The more severe the disease, the more regular and predictable the disease becomes, and the response to the disease is much more predictable in severe illness than in mild illness. And lastly, what kind of diagnosis is presented here in images? It should be very obvious, that's bowel obstruction. And here should be diabetes. If you consider these cases, what you find is that the diagnosis is very obvious, because every diagnosis has three key features. If you have less than three key features, like this, you end up at best with a list of potential differential diagnosis. or in that case, you get a lift that looks something like that.